Hey guys, I hope you're enjoying the course so far. I wanted to include this bonus lecture simply because we've recently had a child in the unit born with this condition, and I made a talk for the NICU residents about tricuspid atresia and calculating the QP to QS ratio, and wanted to make this available to you guys. I think for this course, it's really important for me to distinguish to you guys what's going to be important practically as a general pediatrician or pediatrician in the ED or urgent care center. Um, Differentiate that between what is maybe more uh, relevant to your boards or just a topic of interest. And I think this is the latter. I think tricuspid atresia is so commonly picked up on prenatal ultrasounds or picked up within the first minutes or hours of life that you're probably unlikely to experience this or be the person managing it in the neonatal period. Um, but it is possible you could be the general pediatrician working in a nursery who goes to a delivery to find a child that's cyanotic from tricuspid atresia that was not picked up on prenatal ultrasound. That's unlikely, but possible. I think for all intents and purposes, this is more of a lecture of interest and also to introduce you to some of the ideas of pulmonary overcirculation, pulmonary insufficiency, ductal dependent lesions, and then the QP to QS calculation. So I hope it's interesting and valuable for you. As always, I welcome your feedback at the end. Hope you guys enjoy. So if we recall our 5 T's of cyanotic congenital heart disease, remember the handy memory device that we learned in the Tetralogy of Fallot lecture. Handy meant to be a very, very bad pun. Remember to count to 5. Truncus arteriosus being number 1. Transposition of the great vessels, number 2. Tricuspid atresia, number 3. Tetralogy of Fallot, number 4. And TAPVR, number 5. So of these, tricuspid atresia is the third most common. I'll say in my 5 years of training, I believe I've seen 2, perhaps 3 cases of tricuspid atresia. So anecdotally, I have not come across it very much, but it is the third most common after transposition of the great vessels and tetralogy of Fallot. So it's really worth knowing about. Remember the difference between atresia and stenosis. That's really important here. Atresia means no flow. Stenosis means severely limited flow. Tricuspid atresia is complete absence of flow from the RA to the RV due to, as the name suggests, atresia across the tricuspid valve. That can be embryologically from a few different scenarios. There can be a muscular shelf of tissue that leads to this atresia, a membranous shelf of tissue. The valve itself may be atretic. And then there's a subtype of tricuspid atresia worth knowing about, Epstein anomaly, in which you have downward displacement of the tricuspid valve into the RV, creating atrialization of the right ventricle. That's the buzzword I want you to remember for Epstein anomaly is downward displacement of the tricuspid valve and atrialization of the right ventricle. Epstein anomaly is really different from numbers 1, 2, and 3 here in terms of the clinical course and the surgical management. So that deserves its own talk. I'm not going to go into it much here. What I really hope you take from this talk is that anatomy is everything in this heart lesion. The neonatal course and surgical plan will be completely dependent on the anatomy. And so we'll go into a tree here, a decision tree for how to manage these patients in the neonatal period. Before we jump into that decision tree, let's talk about some associated lesions, and then the next slide, I'll show you an infographic of tricuspid atresia and hopefully kind of cement this in your mind what this looks like and how the blood flows in someone with this condition and the associated lesions that perhaps they have. So associated lesions, number one, ASD. 100% of patients with tricuspid atresia will have an ASD, simply because life is not sustainable without it. You can imagine blood flowing into the RA, reaching that shelf of tissue that's created the tricuspid atresia, and then hitting the septal wall that has no ASD. Where is that blood going to go? It's going to flow retrograde and back out of the RA into the venous system. There'd be no way for blood to flow right to left. And so really you have to have some degree of an ASD in this disease, or else you simply won't survive to birth. An ASD in this heart lesion may be restricted. It may be unrestricted. I think much more common to be unrestricted, because again, children often wouldn't survive to birth if they had a restricted ASD. But this would be a scenario if you did have a child with tricuspid atresia and a restricted ASD with insufficient right to left flow. You may need to intervene. You may need to be calling your cardiac interventionalist to do an atrial septostomy. So keep that in the back of your minds. But 100% of children born with tricuspid atresia will have an ASD. 100% of children with tricuspid atresia will also have some degree of RV hypoplasia, and we'll learn in just a bit that these children go down a single ventricle pathway, in fact, because of the degree of RV hypoplasia that they have. Remember the phrase that's common in cardiology, no flow, no grow, and that will really help you kind of remember the RV hypoplasia, and then in a couple of bullet points here, the potential for pulmonary outflow tract obstruction and pulmonary artery hypoplasia. Imagine the child with tricuspid atresia who has fine enough flow across the ASD such that you have, right to left shunt across that ASD, and then blood flow from the LA to the LV. And then the blood can go one of two places. It can shunt left to right across a VSD, or it can go in the normal physiologic pathway for blood to flow, and that's out the aortic valve to systemic circulation. The RV hypoplasia, the degree of pulmonary outflow tract obstruction and the degree of pulmonary artery hypoplasia is really going to be dependent on the size of your VSD. You see in bullet number 3 here, VSDs will be present in 95% of patients with tricuspid atresia. The degree of restriction or unrestriction across the VSD will really determine how severely hypoplastic that RV is, and then in some scenarios how severely obstructed the outflow tract is, or the pulmonary artery, how hypoplastic it may be. And again, it all boils down to that simple phrase, no flow, no grow. And so we talked about really all of these except for double outlet right ventricle or transposition of the great artery. That there's a strong association with either of those in this situation. And double outlet right ventricle just talks about just speaks to how the aorta arises from the RV. You'll get a little bit better sense of that in the photo or in the infographic that I'll show you next. But double outlet right ventricle transposition of the great vessel is very common and important to know just for their surgical approach. And so we talked about all the associated lesions. What this boils down to, remember my bottom line from the last slide, anatomy is everything here, are the children with this disease going to go down a pathway of pulmonary insufficiency or pulmonary overcirculation, and that will dictate what surgical management they're going to need. So let me show you the next slide, and we'll talk a little bit more about this. Before we move on to the decision tree, let's look at the animated depiction here that I borrowed from Up to Date. Let's start on the left-hand side, type 1B or 1C. and pretend like we're the red blood cell moving through the heart with this lesion. We've entered the right atrium from the IVC or SVC, and we meet resistance and indeed an inability to flow in a forward fashion at the level of the tricuspid valve due to this shelf of tissue that's causing tricuspid valve atresia. So then our only option is to move from right to left across the ASD into the LA. From the LA, we move in a normal fashion across the mitral valve into the left ventricle. Once in the left ventricle, there's an important distinction to make, two important distinctions to make, in fact. A would be, is a VSD present? And B, if yes, then what is the size of that VSD? 5% of patients with tricuspid atresia will not have a VSD like we talked about in the last slide. For those patients, blood can only flow from the LV into the systemic circulation across the aortic valve and into the aorta. There will be no source of pulmonary blood flow in these patients with no VSD. Because of that, these patients are absolutely ductal dependent so that blood can flow left to right across the ductus and supply the pulmonary circulation. So that will be really important for you to ask your echo tech or cardiologist when these babies are undergoing ultrasound after birth. Does the VSD exist? And if it does not, then you need to start Prostin right away so that they have a source of pulmonary blood flow. The other group will be that 95% of patients that do have a VSD. Of those, some will have a restricted VSD that provides insufficient pulmonary blood flow. There will be some left to right shunting across that small VSD. Pulmonary vascular resistance is likely to still be lower than the systemic vascular resistance, especially as the baby gets on into the first few days or weeks of life. So there will be some degree of pulmonary blood flow at the level of the ventricle, but it's likely to be insufficient. And so these children will also be ductal dependent. And so if you've ultrasounded your child with tricuspid atresia and your ultrasound tech or your cardiologist tells you the VSD is rather small and restricted, you also need to start these patients on Prostin. And then finally, within that 95% of patients with a VSD and tricuspid atresia, some will have a very large unrestricted VSD. Blood wants to follow the path of least resistance, and so blood will flow pretty freely from left to right, especially as pulmonary vascular resistance drops. In the very large unrestricted VSD, as pulmonary vascular resistance drops, there will actually be an excess of pulmonary blood flow such that there's more pulmonary blood flow than there is systemic blood flow. And so that's also important to consider in these children. We'll talk about the decision tree in the child with pulmonary insufficiency or absence of pulmonary blood flow versus the child with excess pulmonary blood flow or pulmonary overcirculation. We'll talk about that a little bit more in the next slide. Type 2 on the right-hand side, notice the position of the aorta and the pulmonary artery. These are reversed, and so this is a child with tricuspid atresia who also has transposition of the great vessels. We talked in the last slide about how this is a fairly well-known association in children with tricuspid atresia. Beyond the scope really of a need-to-know level for the general pediatrician, but it's interesting. It's a well-known association, and I just wanted to cover it briefly here. The other well-known association that is also probably beyond the scale of need to know for the general pediatrician would be the child with double outlet right ventricle and tricuspid atresia. And so that would be the child with TA who has a pulmonary artery and aorta both shifted to the right and both arising from the right ventricle. Once again, not important really to commit to memory as a general pediatrician, but a known association that I thought worth reviewing here. And so my hope is that by the time we've made it to this slide, I've already talked about these things, and maybe seeing it in this sort of format will help cement it for you. So we talked about the patient with tricuspid atresia, obtaining the echo on that baby, and really looking for the presence and size of a VSD. That's really going to dictate which pathway that you take here. The patient with a small VSD or absent VSD will have pulmonary blood flow insufficiency, and so they're going to be ductal dependent. It's your task to identify that in conjunction with your cardiologist and start that baby on Prostin. They need some way to shunt blood flow from the systemic circuit to the pulmonary circuit in order to get blood flow to the lungs and oxygenated blood back to the left side of the heart. So very important for you guys to be asking this question of your cardiologist. After starting Prostin, the next step for them will ultimately be a more reliable means of systemic to pulmonary shunting. And so their stage one will ultimately be either placement of a ductal stent. Ductal stents are wonderful temporizing measures, but they are not reliable long term. And so your surgeon and cardiologist, CICU team may go for a ductal stent. The advantage of that is that can be done in a cath lab. But if they feel that the ductus is not open wide enough, if it's not a reliable source of pulmonary blood flow in that particular patient, rather than a ductal stent, the patient may go to the operating room where they have a Blalock-Taussig shunt, BT shunt placed, and that's a subclavian artery to pulmonary artery shunt. Is effectively the same idea as a ductus, but obviously requires a surgical intervention in order for that to be placed. Let's skip over now to the right side of my chart, the pulmonary blood flow over circulation pathway. This would be the baby with tricuspid atresia and a very large unrestricted VSD who experiences worsening pulmonary overcirculation as the pulmonary vascular resistance drops. This patient will not be ductal dependent. In fact, you would do them harm by keeping their ductus open. As the pulmonary vascular resistance drops, that blood flow shunting left to right is only going to get worse. And if you have another shunt, we already talked about the VSD, if you have another shunt like a ductus, they're going to have even more blood flow left to right, and their pulmonary overcirculation will be worse. Your goal for this type of patient is to try to balance their circulation, and you do that by trying to keep their oxygen saturations on the lower end of normal for them. Again, this is a mixing lesion, a cyanotic heart lesion, and so you expect sats probably to be somewhere in the vicinity of 75 to 85% or 80 to 90%, but certainly you do not want saturations 95 to 100% if you can avoid it. And so not providing supplemental oxygen to these patients, trying to keep them a little bit more on the dry side with diuretics so that you're preventing, pulmonary edema and those, those sorts of issues. That'll be your goal for this patient. And then ultimately, within the first month of life, their pulmonary overcirculation will worsen even with your medical therapy. And so their stage one is going to be either a pulmonary band to limit pulmonary blood flow, plus or minus ligation of the PDA if it still remains open even after you've stopped Prostin. After stage one, for the pulmonary insufficient subtype and the pulmonary overcirculation subtype, both will go down this single ventricle pathway. Think hypoplastic left heart here. Same type of idea, except the left ventricle is going to be your single ventricle supplying blood flow to the systemic circulation. And then ultimately your goal with stage two, or the Glen as we call it, And stage 3, the Fontan, as we call that, will be to bypass pulmonary blood flow through the heart so that the LV in a tricuspid atresia patient is only servicing the systemic blood flow, and it's not needing to provide blood flow to both the lungs and the systemic circuits. So you can imagine tricuspid atresia versus hypoplastic left heart. Tricuspid atresia, you have a normal sized LV. Hypoplastic left heart, you have a hypoplastic LV. The tricuspid atresia patients in general will do better because that single ventricle, your LV, is more equipped, more adapted to handle that systemic blood flow. It's a better pump for that systemic blood flow compared to the hypoplastic left heart patient who will go down the single ventricle pathway with their right ventricle providing systemic circulation. And that's kind of, set up for issues long term when you're asking the RV to take on that task of providing systemic blood flow. Okay, guys, so we've learned all about tricuspid atresia, the associated lesions, the pulmonary insufficient subtype and the pulmonary overcirculation subtype, and the surgeries they undergo. For the purposes of breaking this up a little bit, this one did run a little bit long. We'll end this one here, pick up with part 2 next, where we'll talk about the QP to QS equation and calculating that ratio using the example of the tricuspid atresia patient. Thanks, guys.